Okay. So it will record from now on. So anyway, today is our third class and we will be talking about autonomic nervous system. So before I start talking about autonomic nervous system, do you have any question from the content that we covered in the last two events? Do you have any question? You can keep your mics on and interrupt me. And even while I continue talking about autonomic, if anything come to your mind, don't hesitate to interrupt me, turn your microphone on and ask me a question that you may have. So before we start with autonomic nervous system, let's have a quick review of the basics of the nervous system. And as you can see, this is a problem. Uh, okay, how can I do that? Okay, no, I cannot. Let me try without doing too much. Okay, so nervous system. I talked on the first day, first class of this series. The nervous system, we can divide nervous system in terms of anatomy, more like structural classification. In structural classification, we divide nervous system into two segments, which is central nervous system. You can see here, which includes brain and spinal cord, and the peripheral nervous system, that is the communication of the central nervous system with the peripheral parts of the body. And they include so how the central nervous system connect to the peripheral parts of the body. They connect by nerves, actually. So nerves, and we divide the nerves into two groups. One group we say spinal nerves, we have 31 pairs of them. And then we have cranial nerves, there are 12 pairs of cranial nerve. Okay. Now, if we divide the nervous system functionally, then we say there are we can divide into two segments. One is the somatic and the visceral. Okay, somatic and visceral. Now, somatic will have two components, the sensory component and motor component. The visceral will have two components as well, sensory and motor. Now, of the visceral, not the somatic, of the visceral part of the nervous system and visceral motor, that is the autonomic nervous system. So from the definition, autonomic nervous system is a motor nervous system. It doesn't have any sensory unit. The sensory unit that take care of the viscera, involuntary organs, that are called visceral sensory. They are not included within the autonomics. When we say autonomic, it is purely a motor system. Okay. And so what type of motor it will carry? If you see here, okay. Oh, either way, it is causing some problem. Okay. Let me, okay. So if we compare somatic versus autonomic, you can see the somatic, the most important difference between somatic and autonomic is the effector organ. What type of organ they are controlling, right? Because nervous system, the part of the function of nervous system is to control the function of our body, right? Now, the effector organ, the organ that are controlled by somatic nervous system, are the skeletal muscle. Skeletal muscle, you know a lot about skeletal muscle. I'm pretty sure you know more than I do. The skeletal muscles are the voluntary muscles, right? So if we want to contract them, we contract them. If we don't, we don't, because they are under our voluntary control. That's why they are innervated by the somatic part of the nervous system. But then we have smooth muscle in our body, like all the GI tract. We have smooth muscle in the blood vessels. Our heart is composed of cardiac muscle. Those two type of muscle, smooth muscle and cardiac muscle, they are involuntary. We cannot control their movement. Okay, they are involuntary, beyond our control. And also the glands of our body, the glands that produce secretion, they are also, we cannot control the secretion of our glands, that are regulated by autonomic nervous system. So, if we summarize it, the somatic nervous system will control the skeletal muscle or the voluntary organs. Autonomic nervous system will control the function of smooth muscle, cardiac muscle, and glands, which are involuntary. We cannot control their function. And then, if you look at their connection, we say they are one neuron system, the somatic, versus autonomic is a two neuron system. What do we mean by one neuron system versus two neuron system? Here you can see the neuron that is beginning at the central nervous system. This is the cell body of the neuron. Same neuron, its axon goes all the way to the muscle, right? So if you think of a skeletal muscle contraction, for the skeletal muscle contraction, the final nerve arises in the spinal cord, right? So do you know which horn will give rise to the motor nerve from the spinal cord? Are you familiar with that? Because if you look at a cross section of a spinal cord, the gray matter is divided into dorsal column and the ventral column. Do you know which one, dorsal horn and ventral horn? Do you know which horn will give rise to motor nerve for the somatic? You don't know. That is the ventral horn actually. The ventral horn send all the motor nerves, and the dorsal horn receive all the sensory nerves, okay? Anyway, so the nerve, CNS here, what we mean by CNS here is the spinal cord. They arise from the spinal cord, and the same nerve goes all the way to the skeletal muscle. Okay, that's why we call it one neuron system. But look at, if you compare somatic versus autonomic, autonomic will have two segments, sympathetic and parasympathetic. Both in case of sympathetic and parasympathetic, it's not the same neuron that arises from the CNS goes all the way to the effector. You see, that one ends somewhere, and then it make a synapse with the second order neuron, and the second order neuron eventually reach the effector organ and produce its response. Okay, now because this is a synapse here, right? And where the synapse will happen, it will happen in the ganglia. Now two terms that we commonly use when we talk about nervous system. One, we say a ganglia, sometimes we say nucleus. They are same thing. They are collection of cell body. When the collection of cell body is located within the central nervous system, we call it a nucleus. And when this collection of cell body is outside the central nervous system, like here, it is in the peripheral nervous system, we call it a ganglia. Okay, so that's the difference between ganglia and nucleus. Functionally, they are same thing. They do the same thing. Okay, now if you call it is a synapse, the neuron before the synapse, we call it presynaptic neuron, and the neuron after the synapse, we call it postsynaptic neuron. Or if you say the synapse will take place in the ganglia, then we call it preganglionic neuron, and this one we call postganglionic neuron. So you may see we use this term to mean the same thing. Whenever we say preganglionic fiber, we mean presynaptic fiber. When we say postganglionic fiber, we mean postsynaptic fiber. Okay, postsynaptic and postganglionic, presynaptic and preganglionic, they mean the same thing. Now, even on this cartoon, you can see in case of parasympathetic nervous system, which is a division of autonomic, you see you have a long presynaptic and a short postsynaptic, okay? But in case of sympathetic, it's not right. Actually, it should be around here. It has a short preganglionic or presynaptic, and it will have a long postsynaptic fiber that will reach the effector organ. Now, one unique situation you will find in adrenal medulla. Are you familiar with the adrenal gland? It's also called suprarenal gland because it lies right above the kidney. So superior to the kidney, we call suprarenal gland. Or if you think of its secretion, it produces the adrenaline and noradrenaline. That's why it is also called adrenal gland. Okay, adrenal and suprarenal, they are the same thing. So what happened, the presynaptic neuron, when they synapse with the cells of the adrenal medulla, adrenal gland is again divided into two parts. One is the outer side is the adrenal cortex, and the inner side is adrenal medulla. The cells of the adrenal medulla, they behave as if they are postganglionic, sympathetic cells. So the presynaptic fiber come and synapse here, and postsynaptic cell Instead of reaching the effector organ, they secrete some secretion like epinephrine or epinephrine, and those goes into the bloodstream, and bloodstream will take them to the effector organ to produce their response. Okay. Any question up to this point? Anyone? If not, then let's continue further. Now, this
I
slide
have
shows
one.
a summary of the sympathetic and parasympathetic system. In one word, if we say what sympathetic does, we say sympathetic is responsible for flight and fight response. So it is used mainly in emergency, fight and flight. And parasympathetic is more like a normal day-to-day function. It's a rest and digest. So we eat, we rest, we do our normal daily work. That functions are generally controlled by parasympathetic part of the autonomic nervous system. And when we are in emergency situation like flight and fight situation, then generally sympathetic take on actually. So that is the function of sympathetic. That is the main thing. Now, if you look at the arrangement of the sympathetic and parasympathetic, this is, you see, this is the spinal cord, a medulla, and then continue into the spinal cord. Now, these are spinal cord segments. You see, this sympathetic nerve, they arise from T1, first thoracic segment, to L2 segment. That is the source of sympathetic. You don't have any source of sympathetic above, or you don't have any source of sympathetic below. But the structures that lie above this level, they need sympathetic, and the structures lies below this level, they also need sympathetic. But because sympathetic have origin only between T1 to L2, so all the sympathetic presynaptic fibers should arise from there, and then they go up along the sympathetic chain and reach their target. Okay, or they go down along the sympathetic chain and then go to their targets to control their function. Okay, in addition to the viscera, sympathetic also provide innervation to the skin and the sweat glands. On the other hand, if you compare the parasympathetic, you see this is all sympathetic, right? Now parasympathetic, here is the origin of parasympathetic. Okay, so if the red color shows the sympathetic and this blue color shows the parasympathetic. You see around here there is no source of parasympathetic. Parasympathetic either come from the cranium, you see the pons medulla, that area, or at the lower sacral segment, sacral 2, 3, 4. Okay, so the things that come out, the parasympathetic that come out through from the cranial part, they follow the cranial nerves. Okay, some of the cranial nerves have parasympathetic component. Which are those? They are cranial nerve number 3, number 7, number 9, and number 10. So parasympathetic will either come through cranial 3, 7, 9, 10, or they will come through S2, 3, 4, sacral 2, 3, 4, and they will form the pelvic splanchnic nerves. Okay, so they will innervate the viscera of the pelvis. I will get into the detail of that. Now, so because of the source, sympathetic is as arising from T1 to L2, we call it thoracolumbar outflow. You see, either they come from thoracic area or from upper lumbar area. We call thoracolumbar outflow for sympathetic. For parasympathetic, depending on their origin, we call them craniosacral outflow. Either they will arise, their outflow will come either from the cranium or from the sacrum. We call it craniosacral outflow. So sympathetic is thoracolumbar and parasympathetic is craniosacral depending on their origin. Okay. Now, there are a lot of similarities between sympathetic and parasympathetic. Number one is both of them, they control the autonomic, the involuntary structures like smooth muscle, cardiac muscle, glands, right? Those are their targets. The targets are the same, okay? And both of them have two neuron systems. The first neuron arises in the central nervous system like this one from the spinal cord or from the part of the brain or from the spinal cord, and the second order neuron lies within the peripheral part of the body, right? Here you can see for sympathetic, most of the ganglion are just close to the vertebra, okay? We call just next to the vertebral bodies. These are sympathetic chain ganglia, but in addition, there are some in the abdomen as well, We call them pre-aortic ganglia because they lie just anterior to the aorta. Okay. For parasympathetic, you remember for sympathetic, I said they will have short presynaptic and long postsynaptic, right? For parasympathetic, they have long presynaptic and short postsynaptic because in most of the cases, their ganglia or where their second order neuron begins, that cell body lies within the organ that they provide innervation to, like for heart. So the vagus nerve arises from the medulla, right? And then it has a long preganglionic fiber goes all the way to the heart. And within the tissue of the heart itself, they have the ganglia. So they synapse there and send a very short postsynaptic neuron to provide innervation to the heart. It's the same for all organs, right? So that's how. So they are different. They are pre-sympathetic will have short presynaptic, long postsynaptic. Parasympathetic will have long presynaptic, short postsynaptic. Okay. And in case of both of them, presynaptic axon will release acetylcholine. Okay, presynaptic neuron in case of both sympathetic and parasympathetic, their neurotransmitter is acetylcholine. Okay, but how they're different? Now they are very different actually. When they, even though they work on the same organ, but on the same organ, their stimulation produce opposite response. I will talk about that in detail. And they are different location in ganglia in peripheral nervous system. As I said, for sympathetic, main ganglia are located just next to the vertebral column. But in case of parasympathetic, most of the ganglia are located in the organ that they supply. Okay. And as I said, they have different neurotransmitters they release, even though presynaptic will always release acetylcholine. The postsynaptic, in case of parasympathetic, they will release acetylcholine. In case of sympathetic, they are different. They will release norepinephrine and epinephrine, right? But they can do acetylcholine as well at times. And different effects as when you stimulate sympathetic or parasympathetic, if they innervate the same organ, they will produce the opposing response. Now, in this chart, there are some responses. I summarized some of them. Now, even though I say most of the organ will receive both sympathetic and parasympathetic, and stimulation of them will produce opposite response. For an example, if you on the heart, if you stimulate parasympathetic, the heart rate will go down and the contractility of the heart, of the ventricle mainly, will go down. So the parasympathetic stimulation on the heart will decrease the force of contraction and it will decrease the heart rate. In case of sympathetic, it will go to the same thing. It will go to the SA node, which is the pacemaker of the heart, and the atrial and ventricular muscle. Their target is the same, but when you stimulate the sympathetic nervous system, they will produce just opposite response to parasympathetic. Parasympathetic decrease the heart rate, sympathetic will increase the heart rate. Parasympathetic stimulation will decrease the force of contraction and of the muscle, ventricular muscle mainly, and sympathetic stimulation will increase the force of contraction. Okay. Now look at the urinary bladder. Urinary bladder has muscle actually. It's a muscular bag, right? And that it has a sphincter. Now, parasympathetic, we say for the normal function, its micturition is a normal function, right? Normal physiological function. So what parasympathetic stimulation will do, it will contract the muscle of the bladder and it will cause the relaxation of the sphincter. What will be the net effect? Micturition is possible. Someone can do micturition only if parasympathetic is in control, because parasympathetic will cause contraction of the muscle of the bladder and it will cause relaxation of the sphincter of the bladder. But sympathetic, what sympathetic will do, it will do just exactly the opposite. It will relax the bladder muscle and it will cause the contraction of sphincter. So if you think physiologically, or say if you are scared, you see, if you are scared, you are in emergency situation, you will not be looking for the restroom actually to go for micturition, right? And that is done by sympathetic, because when you are in emergency, when you are scared, when you are urgent situation, you are fighting with something, you are flying from something, so you will not have the urge to go to the restroom for micturition. Why? because at that time your system will be under the control of sympathetic. What sympathetic will do, it will, it will relax the muscle of the bladder, so you will not feel the urge of the tension in the bladder, and your urethral sphincter will be constricted, so micturition will not be possible. But when the emergency will be done, then you come back to rest, then parasympathetic will take charge, and it will cause the contraction of the bladder, and it will cause the relaxation of the urethral sphincter, so micturition is possible. So you see that show you a difference between the normal function and emergency situation. Okay. Now, that is the normal situation. In most of the organs, you see both sympathetic supply and parasympathetic supply, and their stimulation will produce opposing response. But there are some exceptions. Some targets, they receive only sympathetic. There is no parasympathetic innervation in some of the organs, like blood vessels. Blood vessels are supplied only by sympathetic, and sympathetic stimulation will cause contraction of the blood vessel. Sweat gland. Sweat gland is provided innervation only by sympathetic. There is no parasympathetic innervation there. Pilomotor is the erector pili muscle, the muscle, the erector pili muscle. These are muscles related to hair follicle. They are innervated only by sympathetic. And the dilator muscle of the iris. You see, our iris, the aperture of the iris is controlled by two sets of muscle. Okay. Two sets of muscle. One is called the dilator pupillae muscle that constrict the pupil. The other one is called the constrictor pupillae muscle that is controlled by parasympathetic, that will make your pupillary aperture small. Okay, but they are little different in their function. You can see it's not the same muscle. That for in case of heart, both sympathetic and parasympathetic work on the same muscle, right? They both work on SA node. One reduce the heart rate, one increase the heart rate. But in case of pupil, it's little different. Pupil has two set of muscle. One is called dilator pupillae muscle, that when you stimulate that muscle, that will dilate the pupil. And then another one is constrictor pupillae muscle. When you stimulate it, pupil will be constricted. So two muscles are controlled by two different nervous systems. The constrictor pupillae muscle is controlled by parasympathetic, and dilator pupillae muscle is controlled by sympathetic. So under normal circumstances, there is a balance between sympathetic and parasympathetic. So that's why you see a normal aperture of the pupil, right? Now, if you block the sympathetic, parasympathetic will become unopposed, and it can make the pupil very constricted. Also, the opposite is true as well. If you can block parasympathetic, and if the parasympathetic is not working, then sympathetic will take upper hand, and it will tend to dilate the pupil. But the difference here is they are working, sympathetic and parasympathetic, they are producing the response by working on two different muscles. Not like in the ventricle, where sympathetic and parasympathetic both are working on the same ventricular muscle. One is reducing the force of contraction, the other one is increasing the force of contraction. Did you get that? Are you okay with that? Good. So that is okay. Now, if we say some target, they receive only parasympathetic. As I said, constrictor pupillae muscle, they don't have any innervation from sympathetic, right? And ciliary muscle of the eye, that is something very important. You see, when something comes close to our eyes make an adjustment. I don't know how, if you're familiar with that. That is called accommodation. Now, accommodation means when things come close to our eye, our muscle of the eye, one set of the muscle of the eye, they are called ciliary muscle, they contract. So when they contract, they loosen the pressure on the lens. So lens, because of its elasticity, it increases the convexity. So even when this thing come close, we can still see the things properly. The vision is not blurred. But if you lose parasympathetic, you will lose ciliary muscle, and also with age, your ciliary muscle become weak. You cannot accommodate. You see, you guys can read without a glass, but for me, I need a glass here. You see, this is what, because my ciliary muscle is not working well, So I'm having some aid, so that I add some power to my eye, so that even though my ciliary muscle is not working properly, I can still see things when they come close. Okay. So this ciliary muscle is related to accommodation of the eye. Why we need accommodation? To see the near objects, okay, when the things come close. Okay, now in some cases, their effect is synergistic. We say as a general rule, they will be opposite to each other, right? But like in case of iris, even though they produce the response by working on two different set of muscle, but they control the aperture of the eye, pupil, right? So they are synergistic. And also in male sex organ, parasympathetic stimulation causes erection and sympathetic causes ejaculation. So those two functions are not opposite to each other, they are synergistic to each other. Okay, and in some cases they are complementary. So complementary to each other, you can see in the salivary glands, sympathetic stimulation will produce enzyme rich secretion which is thick, and parasympathetic stimulation will produce watery secretion which is watery secretion. That's why when you are in emergency situation, you will have dryness of the mouth. Why you have dryness of the mouth? Either sympathetic stimulation or parasympathetic inhibition will cause dryness of the mouth, because who will produce watery secretion? Parasympathetic. Who will produce thick secretion? That is sympathetic. Now, if you are in an emergency situation, now your parasympathetic is not in charge, your sympathetic is in charge. That will produce thick saliva, so you will feel dryness of the mouth. Okay, in the absence of parasympathetic. Okay. In any question about the opposing response or synergistic response? Do you have any question? But as a general rule, remember, most of the cases they will innervate the same organ, and stimulation of them will produce different response. But you need to know the exceptions, because blood vessel is an absolutely important exception. It produces only the contraction of the blood vessel. That's why a lot of blood pressure lowering agent, these are so you block the sympathetic, because sympathetic stimulation will cause constriction of the blood vessel, that will elevate the blood pressure. But if you can dilate the blood vessel, the blood pressure will go down. Okay, so that's something very important. Okay, so now if we go further, I don't know why cannot I move these slides? Okay, here. Okay, now there is a term you will see, we sometimes say predominant tone, predominant basal tone. Who is normally in charge? Okay, we call it predominant basal tone. Most of the predominant basal tone are controlled by parasympathetic, like iris. Normally, our pupil is not dilated. Normally, our pupil is partially constricted. So, which means who is in charge under normal circumstances? It is parasympathetic. So, like heart, our heart is, now we are sitting and listening something, talking to you guys. Now, my heart is not pounding, right? My heart is not beating very fast. So, normally, heart is controlled by parasympathetic. So, heart is not beating very fast. But if you are scared of something, you will see your heart will start beating very fast. But normally, who will control the normal tone of the heart rate? That is parasympathetic. And like GI tract, your urinary bladder, I talked about urinary bladder, right? Normally, if you drink a lot of water, you can go and you can void your bladder. But if you are in emergency situation, you are scared, you cannot void your bladder. Why? Because now bladder muscle is relaxed and sphincter is constricted, so you cannot void your bladder. You cannot empty your bladder. Okay. Now, some of the structures, as I mentioned before, they are innervated only by sympathetics. So their basal tone is controlled by sympathetic, like blood vessel. Very important, practical for all practical purposes. Sweat gland, they are sympathetic, but one unique situation about sweat gland is that we said, as a general rule, postsynaptic sympathetic, their their neurotransmitter is norepinephrine, epinephrine. But in case of sweat gland, they are postsynaptic sympathetic, but they secrete acetylcholine. Okay. Now, when we say we block sympathetic, or we block parasympathetic, or we say, sometimes you see, we say ganglion blockade or denervation. When you do that, what it will do, it will be opposite to the predominant basal tone, right? Normally, iris predominant basal tone is parasympathetic, right? So now, if you have parasympathetic loss in the eye, it will be opposite to the basal tone, so the pupil will be dilated, something like that. So when you block, when you do a ganglionic blockade, or when you denervate something, the effect will be opposite to the normal basal tone. Okay. Now, look at let me have both of them. So this is a sympathetic, parasympathetic, and this is a sympathetic neuron, right? Now look at what happened. Normally, the choline goes into the presynaptic neuron, and they combine with acetyl-CoA and choline under the influence of choline acetyl transferase. They form acetylcholine. That's how neurotransmitter is formed, right? And neurotransmitters are stored inside the vesicle, right? And then when the nerve impulse reaches the presynaptic terminal, acetylcholine will be released in the synaptic cleft, and it will bind to, okay, let me see, I need to move this one again. So it will bind to the postsynaptic cholinergic receptor in the postsynaptic membrane and produce its response, right? Now, we said we can modulate their function. How can we modulate their function? You see, when acetylcholine is released in the synaptic terminal or in the synaptic cleft, you don't want acetylcholine to be there for a long time so that cholinergic response will continue, right? So what happened? They are broken down by acetylcholine esterase that will break down the neurotransmitter so that its action will be terminated. Now, if you apply a medication or a medicine that will inhibit the enzyme, so this breakdown of acetylcholine will not occur, so acetylcholine will be working longer. Okay, so see, how do we modulate the function? Like botulinum, that is a kind of toxin that prevent the release of acetylcholine from the presynaptic terminal. Now, if someone has botulinum or toxin, or you inject some botulinum on someone, what it will do? It will prevent the release of acetylcholine in the synaptic cleft, so there will be no response, right? That's how you block the cholinergic response. Now, there is another thing called hemicolinium, right? Hemicolinium I'm just giving you some example for you to understand. Hemicolinium will stop the transport of choline into the presynaptic terminal. If you don't have choline in the presynaptic terminal, there will be no acetylcholine secreted. So in that way, you can block cholinergic response. You can block cholinergic response by this one. You can block cholinergic response by vesamicol. What it will do, it will also really decrease the secretion of acetylcholine, and it will inhibit the entrance of acetylcholine into the synaptic vesicle and the release of acetylcholine, which means in a way it will be anticholinergic, it will be anticholinergic, it will be anticholinergic. So these will all act against the cholinergic transmission. But if you want to enhance the cholinergic transmission, one way you can do, you can block the enzyme, so that acetylcholine will work longer in the synaptic cleft, right? In the synaptic cleft, so there will be more acetylcholine available there, so that they can bind to the receptor and they can produce their function. Now, if we look at the adrenergic side, okay, now you see, norepinephrine is their main neurotransmitter, and that is released from tyrosine, right? Or synthesized from tyrosine to dopa to dopamine to norepinephrine. Okay, now you see, if you apply reserpine, which is an important medication, they are used as antihypertensive. What it will do, it will inhibit the secretion of norepinephrine in the terminal. That's how you reduce the adrenergic response. If you have more adrenergic response, what it will do to the blood pressure? Can you tell me, if you have more adrenergic stimulus, nor sympathetic stimulus, what will be the net effect on blood pressure? Blood pressure will go up or blood pressure will go down? Blood pressure will go up, right? Why? Why blood pressure will go up? Who can tell me? Say something.
Because the Vasodilation is correlated with the sympathetic nervous system, so the blood vessels will constrict.
So vasodilatation and blood vessel will constrict. They are two opposing things, right? Not vasodilatation, vasoconstriction is related to adrenergic nervous system, right? So if you have more epinephrine in the system, what it will do, it will cause the constriction of the blood vessel, right? Constriction of the blood vessel. So blood pressure will go up. And also what it will do on the heart, it will increase the force of contraction. The heart will pump more forcefully, more blood will be ejected on the blood vessel. You have more blood in the vessel and the vessel is constricted, right? And heart is beating fast. All these things combined together will increase the blood pressure. So to reduce the blood pressure, you reduce the secretion of norepinephrine. So one of the ways is that you block here, or you block here, right? Or you block here, guanethidine. So it will decrease the release of norepinephrine there, right? Now, in some cases, you need the system to be excited, to remain excited. Now, say like the day before your exam, you want to be alert, you want to be alert. So you want to, so that for that you take a lot of coffee or, the energy drinks, they all contain, these are adrenergic stimulus. So what they will do, when the norepinephrine is released, it is quickly go back, actually pumped back into the presynaptic terminal to terminate their function. But if you add cocaine to the system or pseudoephedrine to the system, what it will do, it will reduce the reuptake of norepinephrine. So norepinephrine, they will stay in the system longer, so you will feel excited, like too much coffee. If you drink, it's things, affect different people differently. There are people who, if they drink coffee after 8 o'clock, they cannot even sleep, because their system is so sensitive. So they will have more epinephrine in the system, so they will feel excited. For you to go down and sleep, your central nervous system needs to come down, right? So that you can go to sleep. But if you are excited, if you hear that you got your paper got accepted, you got a wonderful result, if somebody come and say, you are very sleepy, see, maybe at 10-11 p.m. you are feeling very sleepy, you got an email from the journal editor that your paper got accepted. Oh my goodness, do you think you will go immediately to sleep? You cannot go to sleep immediately. Because why? Because that news, that will cause an adrenaline rush. And then while adrenaline is in the system, you cannot sleep immediately. So you just cannot say you are expecting to and hoping that paper to be accepted because your PhD is dependent on that and everything. And then when you are extremely sleepy at midnight, you got that good news from the editor, say, oh, we are happy to inform you that your paper got accepted. Oh, so that is a real good sympathetic stimulus, okay? Anyway, so that's how the sympathetic and parasympathetic, they will work. Now, there are some, I put some anatomy here. Actually, if you are interested, you can see them. What happened, you see, if you took a section of the spinal cord, okay, if you take a section of the spinal cord, you see these are spinal nerves, right? Do you know how a spinal nerve is formed? You see, this is sensory, this is motor part. They both come together and they form a spinal nerve. Spinal nerve is, we say, peripheral nervous system has two different type of nerves. One is spinal, the other one is cranial, right? Now, in this case, there is no nerve. You will not find a sympathetic nerve, So how the sympathetic will reach the skin or reach any body wall tissues? Their origin is here. See, this is one horn we call dorsal horn for sensory, ventral horn for motor, or motor nerve will start from here. But you see a lateral horn here. This lateral horn is present only between T1 and L2. You don't see it in other segments. And that is the source of sympathetic. So sympathetic will start from here. Let's see how sympathetic starts. So you see, this is the source, right? And then you have presynaptic sympathetic, right? We said sympathetic is an autonomic, so it should be two neuron system. So this neuron, if it goes all the way to the blood vessel, do you think it will be effective? It cannot be effective, because we said for autonomic, both sympathetic and parasympathetic, to be effective, they have to have a synapse somewhere, and only postsynaptic neuron will be effective. So if we continue, see what this presynaptic will do. So this is a ganglia, right? Now you see presynaptic neuron is reaching the ganglia where they will synapse, and postsynaptic neuron will rejoin the spinal nerve and will be distributed with the spinal nerve. These two parts, one that leave the spinal nerve to join the ganglia, we call it white communicating rami. You don't have to worry much about this. These are more anatomy. And then the fiber that join back the spinal nerve to be distributed to the body wall, they are called the gray communicating rami. Okay, so that's how sympathetic originates. It's originate from the spinal cord, but not from where the somatic nerves arise. These are the somatic nerves. Okay, now parasympathetic arise from the sympathetic arise from here, from the lateral horn of the spinal cord. Oh, whose internet connection is unstable? Mine. Can you hear me? Okay, so you see, look at how sympathetic is coming out from the lateral horn. You know, they follow the ventral rootlets, and then they leave. This is the sympathetic chain, right? Sympathetic chain, and so they leave the spinal nerve to come to the ganglia. They synapse, and they join back the spinal nerve. Now these are postsynaptic fibers, so they can be effective, right? Okay, see, they come here and then go back. Dotted lines are postsynaptic neuron, which means they can be effective, right? So that's how they are. So now, see, this is the situation in T1 to L2, you have a lateral horn. But above the T1 and below the L2, you don't have a lateral horn, right? But you still need sympathetic supply. So what it will happen, so between the T1 to L2, all the presynaptic fibers will come out. And then for the structures above the T1, they will go up inside the sympathetic chain, and then they will reach their corresponding level. They will synapse there, and postsynaptic fibers will go out. This is for the structures around C1 to C8, how the presynaptic sympathetic will go. This is for the structures which are below L2. They have to arise. Presynaptic have to arise between T1 and L2. After that, there is no source of sympathetic. So they have to arise from T1 to L2. And for the structures which are located between L3 to coccygeal 1, they will go down along the sympathetic chain to reach their targets. Okay, don't worry much about these things. These are more like anatomy. Okay, now we talked about sympathetic going to the body wall, right? Along, so how the sympathetic will, only thing that you have to remember, how sympathetic will reach the body wall. You don't see any sympathetic nerve. So how they are going? They are going along the spinal nerves. Sympathetic will join the spinal nerve, and spinal nerve will take them all the way to their target. Okay. Now that is how they will go to the body wall. Now what about the viscerals? Viscerals means like heart, lung, all this GI tract. Look at this fiber. This is the sympathetic chain, right? So these are the fibers that are joining this spinal nerve. You see these two gray communicating, gray rami, white rami. They are joining the spinal nerve to be distributed. In addition to that, there are some fibers coming this direction. Okay, they will come here, and you see this is the esophagus, and they will be wrapped around the esophagus, and they will provide nerve supply to the heart and lung in the thorax. And then some of them, you see, these are, we call greater thoracic, lesser thoracic, and least splanchnic nerve. They will enter the abdomen. You see, this is aorta here. They will synapse in the ganglia, which are located anterior to the aorta. We call them pre-aortic ganglia. They will synapse there, and they will provide innervation to their targets. Okay, all the viscera. Now, this is the exception I told at the beginning as well. I said most of the sympathetic, they arise from the, you see, look at three things here. One is sympathetic will arise from the lateral horn of the spinal cord, okay? And most of them, they will synapse at the sympathetic chain here, sympathetic chain. But look at this fiber. These fibers are arising from the lateral horn, but they don't synapse in the sympathetic chain ganglia, right? So they miss that chance. So they leave presynaptic, and they arise here around the pre-aortic ganglia. They didn't synapse there as well. Okay. Now, these fibers, they are going to the adrenal medulla. I told you at the beginning that adrenal medullary cell behave as if they are sympathetic ganglia. So these fibers, which didn't synapse here, these are pre-aortic ganglia. These are sympathetic chain ganglia. They miss both places. They don't synapse. They go all the way, remain presynaptic, and they synapse in the adrenal medulla. This is the adrenal cortex, okay, and this is the adrenal medulla. They will synapse with the adrenal medullary cell in, and then adrenal medullary cell will release epinephrine and norepinephrine that will be released into the blood. You see the blood vessel around it, it will release to the blood, and blood will carry it to the organs to produce sympathetic response. Okay. So sympathetic, its origin is always the same from the lateral horn cells of the spinal cord. Okay. Which level? T1 to L2. That's why we call it thoracolumbar outflow, where they have to synapse somewhere. So where they will synapse, either they will synapse in the sympathetic chain ganglia that is lateral to the body of the vertebra on two sides of the body. Most of them will synapse there. If they don't synapse there, they can synapse in some pre-aortic ganglia. There are some ganglia, sympathetic ganglia anterior to the aorta. We call them pre-aortic ganglia. They have different names. If you have interest, you can learn celiac, aorticorenal. But it depends on the. They are named according to the branches of the aorta that they are close to. Celiac trunk is a very important branch of the aorta, and if they are close to the celiac trunk, like this one here, this is celiac trunk. So this ganglia around the celiac trunk, we call it celiac ganglia. This is superior mesenteric, so artery. So the ganglia around the superior mesenteric artery, we call superior mesenteric ganglia, like that. So again, if we summarize, so this is they originate in the lateral horn cell, and this is the sympathetic chain ganglia. You see, even though the source of the sympathetic is between T1 to L2. This is the sympathetic extent, right? So whole thoracic and upper to lumbar. But look at the sympathetic chain. Sympathetic chain is extend from all the way from the root of the neck all the way to the coccyx, which means even though source of the sympathetic is limited between T1 to L2, but sympathetic chain ganglia are present from the base of the neck all the way to the coccyx. Now, if you have the topmost ganglia here, then we need some sympathetic inside the brain as well, right? So they will all go from superior cervical ganglia. This one, we call it superior cervical ganglia. They originate from there and they go along with the internal carotid artery. We call them internal carotid plexus. Through the internal carotid artery, they go to the brain tissue and provide innervation to the brain. Okay, inside the brain, the tissue inside the brain. Now, this one is, so now look at the, you have a question? Anyone wanted to say something?
Yes. Sometimes people get, yes. Sometimes people get an inflamed ganglion. What exactly is that caused by, and what's happening inside of the ganglion?
So inflammation in the ganglia is sometimes, sometimes the ganglia, more than inflammation, sometimes ganglias are pressed by the surrounding structure. Like for an example, one very simple common example is that, around the, if some people have the tumor in the root of the neck, root of the lung, lung is in the thorax, right? So now any tumor in the root of the neck, root of the lung will press on those ganglia over there, and they can interfere with the function of the ganglia, and they will cause some problem. But generally, infection in the ganglia is not very common. But if any infection involve any ganglia, they will interfere with the function of the fibers that originate in that particular ganglia. Okay, like for an example, like this one, celiac ganglia, right? The structures that are innervated from the postganglionic fibers arising from celiac ganglia will provide innervation to the GI tract, upper part of the GI tract, okay, from the abdominal esophagus all the way to the transverse colon. They will all get their sympathetic innervation from the fibers originating from the celiac ganglia. Now, if you have an aortic aneurysm, have you heard of the term called aortic aneurysm or any tumor around this area? If they press on because they are a neuronal structure, right? They react very quickly to any pressure on them. So if any growth of tumor or anything that compress on the celiac ganglia, so those postsynaptic fibers arising from celiac ganglia will all have problem. So all the areas innervated by that ganglia, postganglionic fiber arising from celiac ganglia will have problem. Now, what type of problem it will have? It will depend on how much is the problem and how many fibers are affected by that.
Is that the same problem caused or which causes sciatica? I know sciatica is a big problem with a lot of
No,
the
sciatica
elder
is
people.
different. Sciatica is not because of autonomic. Sciatica is because of the, sciatica, okay. Because you see, sciatic nerve is a big nerve, right? So it arises from the sacral region of the body. I don't know whether you have seen sciatic nerve. It's the largest nerve of the body. Now, so the sciatic nerve will originate from here, but sciatic nerve is formed by the spinal nerves. It's not autonomic nerves, it's somatic nerve. Okay, now the somatic nerves, the roots of the sciatic nerve are coming out through the intervertebral foramen from the sacral, lumbar and lower lumbar and sacral region, right? Now, if you have intervertebral disc prolapse, what they can do, they can compress on the fibers of the sciatic nerve, they are coming out. So then you can have all sorts of problem actually from the sciatica. That is the compression of the nerve. It's a nerve compression, but that is the compression of somatic nerve, not an autonomic nerve. Okay. So here you can see this is the sympathetic. Look at this. Sympathetic originate from T1 to L2, but you see sympathetic chain ganglia is extended from base of the neck all the way to the coccyx, and you see fibers coming from this one as well. See, and most of the fibers from here go to the brain actually to provide innervation to the brain. Okay. Now parasympathetic. We said parasympathetic arises from two different areas, so it's not continuous. For sympathetic, it was continuous, T1 to L2, right? Lateral horn. But parasympathetic, either they will come through cranial nerve, 3, 7, 9, 10. You have to remember that. 3, 7, 9, 10, that is the parasympathetic. 3 is oculomotor, 7 is facial, 9 is glossopharyngeal, 10 is vagus, right? So parasympathetic will come either from the cranium or from sacral 234. Again, around sacral 234, you will see a lateral horn. So the lateral horn from sacral 234 will provide, the parasympathetic, right? Now, which area they will supply? Okay, okay. So which area they will supply? Let me do it like this. So this 379, they will provide innervation only to the structures around here, face, okay? So you going to the eye, going to the salivary gland, going to the salivary gland, right? That is 3, 7, and 9. They will not go down below the face. But 10 is special. 10 will provide innervation to the heart, to the most of the GI tract, right? 10 will cover. Are you familiar with the foregut, midgut? Foregut is the part of GI tract. Okay, so we don't have to worry much about it. We divide the gut into 3 different parts: the foregut, midgut, and hindgut. The foregut ends at the second part of the duodenum, right? So above that second part of the duodenum, we call it foregut. From the second part of the duodenum at the opening of the major duodenal papilla all the way to the end of transverse colon of the large intestine, that is called the midgut. And from the descending colon all the way to the rectum anal canal, that are part of hindgut. So the vagus will cover all structures in the thorax and all the foregut and midgut. You see, all the way to the end of transverse colon, that is all vagus territory. Now below this line, the descending colon, transverse colon, rectum and anal canal, they are all, they get their innervation from S234. So the origin of sympathetic was simple, right? We say thoracolumbar outflow beginning at T1, ending at L2, but that's why we call thoracolumbar. But parasympathetic origin, we call, in terms of origin, we call them craniosacral outflow. What is the cranial outflow? How is the cranial outflow coming from? Cranial outflow is coming through 4 cranial nerves. They are 3, 7, 9, 10, those 4 cranial nerves. And in the S2, 3, 4, there are lateral horn again. Those will give rise to pelvic splanchnic nerve, which will provide parasympathetic innervation to the hindgut, the last part of the GI tract, and also the pelvic organs. That is innervated by the parasympathetic. Okay, so let me see. Craniosacral, so it's you can have this things here. It's a craniosacral, what craniosacral means and how do they come. You can go over them and let me see. Oh, okay. You see, parasympathetic, except for in the cranial will do 379 will do only the head and face. Below the neck, from the neck all the way to the end of transverse colon, it is all vagus. Remember that. Only the hindgut, which begin at the descending colon, and the pelvic viscera, they are done by pelvic, we call them pelvic splanchnic nerve. They are parasympathetic. Where they are coming from? They are coming from sacral 2, 3, 4. That's why we call it craniosacral. Cranial outflow is through 3, 7, 9, 10, and sacral outflow is from sacral 2, 3, 4. So you see how this parasympathetic, these are all mixed fibers. You see, this is sympathetic chain. So these are all fibers are all mixed up. Sympathetic, parasympathetic, they are making a plexus here, and they will provide innervation to these organs. Okay, so this blue highlighted areas, these are parasympathetic innervation of vagus. So vagus from here, from the larynx all the way to the transverse colon, is vagus, and then the last part of the colon and the anal canal and the pelvic viscera, they are innervated by not vagus, we call them pelvic splanchnic. Where they're coming from? They're coming from sacral 2, 3, 4. So you see, look here, it's showing you see the sacral, this is sacral 1, sacral 2, sacral 3, sacral 4, spinal nerve, right? So they are giving rise to, because they have lateral horn as well, they are giving rise to parasympathetic nerve that form the pelvic splanchnic nerve. Okay, splanchnic means viscera, the nerve that innervate the viscera. Pelvic splanchnic nerve, what type of nerve are they? They are parasympathetic. What is their function? They will provide innervation. So this is a female organs. This is a male. You can see the uterus here. You can see the penis and testis here. So this is pelvic splanchnic, will provide innervation to the last part of the GI tract and the pelvic viscera, and they will originate from sacral 2, 3, 4. You don't have to go into detail anatomy. Just know that the parasympathetic will arise either from cranium or sacrum. How they will arise from the cranium? Through 4 cranial nerves. Which 4? 3, 7, 9, 10. Those will carry the parasympathetic fibers, or they will come from sacral 2, 3, 4. Sacral 2, 3, 4 have lateral horn like T1 to L2 for sympathetic. The sacral 2, 3, 4 will give rise to pelvic splanchnic nerve. They will provide parasympathetic innervation to the terminal part of the GI tract and the pelvic organs in both male and female. So this is a summary of the abdominal, you see sympathetic coming from T5 to L3, they are providing sympathetic innervation, and parasympathetic in the abdomen is all coming from vagus all the way to up to here, the end of transverse colon, and the last part of the colon, the descending colon and the rectum anal canal, they are coming from sacral 2, 3, 4. Okay, see. So this is the summary of the abdominal autonomics. You see, the sympathetic is coming from the lateral horn and then provide innervation. So they can synapse either in the sympathetic chain ganglia, or they can synapse in the pre-aortic ganglia and provide innervation, right? Now for the parasympathetic, it will all vagus, right? Because the 379, they stayed within the face. They don't come even on the neck. From the neck below, It is all vagus will provide parasympathetic innervation. How far? Vagus will begin at the larynx all the way to the end of transverse colon. That is all vagus innervation, parasympathetic. A descending colon, sigmoid colon, rectum and anal canal, the terminal part of the GI tract and pelvic organs, they will receive their parasympathetic from segment sacral 2, 3, 4. They will form a plexus of nerve. We call them pelvic splanchnic nerve, and they will provide innervation to the last part of the GI tract and the pelvic viscera. I think that's all I have. And if you have any question, we can talk. Okay, let me stop sharing the screen and let's see. Oh, we lost one student in the middle. Anyway, I will upload the video. So did you get hold of the video of the last one? Good. So, and then today one student had problem with, because we are in under inclement weather actually. So I had this one. Today's one is more important. I have to the upload the video. So I will do it soon, say like within an hour or two. You will get access to that. So now the thing is that to cover the whole autonomic in one class is a bit too much. I know I went through some of the areas pretty quickly. I understand it, but if you have any problem, any question, don't hesitate to let me know. You can send me email or send me text message, whichever way is convenient for you. But at this point, do you have any question that I can answer?
Do you mind posting these slides as well?
Oh yeah, I will. And
Perfect.
so
Thank you.
I posted the slide. I just re-uploaded the slide of the first lecture. Did you get it? Is it working this time? Yeah, I was surprised why all the slides were blank actually on the previous one. I don't know. I will upload the slides and the power as a PowerPoint, and also I will upload the video file. Okay. And if you have any question, don't hesitate to let me know. Okay. So then let me